Thank you all for coming. I can start with, it's a very nice weather outside, and I'm very pleased to have seen Cork as well. And so thank you very much for being able to visit in Cork. It's a beautiful city. We'll certainly come back. So what I've been asked to talk about is clinical biomarkers in IBS. And I'm standing for my colleague Magnus Simrén, who once more sent his apologies for being not able to make it this time. There has been an ongoing, or there is an ongoing work in definition of IBS, which for today is based purely on symptoms, with the addition of the use of a reasonable number of investigations. But the idea with the criteria is to turn attention from the negative exclusion diagnosis into a positive diagnosis, where you identify a characteristic symptom complex where you with rather high certainty can tell that this is IBS. If you look upon the individual symptoms that has been part of the different criteria regarding IBS, starting out with the Manning criteria in the late 70s up until now with the Rome 4 criteria, you can see that, not surprisingly though, that the individual symptoms, the individual symptoms in this meta-analysis, which involves 6 studies, not all of the studies includes all of the symptoms, but the number of patients included in each symptom is quite impressive. You can see that the sensitivity and specificity for each symptom is highly variable, and no one really expects that one single symptom should have a high sensitivity and a high specificity for identifying IBS as a symptom-based biomarker, you can say. Combining symptoms into criteria, though, where the symptoms are associated with each other, improves both sensitivity and specificity, both when it comes to Manning criteria and the different versions of Rome criteria there is. But the addition of red flags and some kind of biological markers also affects this. In these studies, you can see that absence of red flag symptoms like late debut of the symptoms in life or blood in stools, in combination with normal calprotectin, increases specificity but decreases sensitivity. There are other studies showing that also adding psychological factors, other symptoms than GI symptoms, affects the sensitivity and specificity, but not in a way sufficient to tell us that we have a good biomarker of disease. We should remind ourselves before I go on, what is a biomarker? A biomarker is a characteristic that is measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to a therapeutic intervention. So this means that a biomarker can be useful both as a diagnostic tool, as a tool for staging, as an indicator of disease prognosis, or used for prediction and monitoring and clinical response to an intervention. And there are indications, at least, that some biomarkers can be useful from one or a few of these aspects already, but with a lot of wide areas of uncertainty, though. And the potential biomarkers that we will look into today is both related to the gut, but also to the gut-brain interaction process with psychological factors, and also when it comes to the difficult processing of pain. The traditional, the classic pathophysiological factors that has been observed in IBS during the last decades are related to motility and sensitivity, and to some extent also secretion. And there are links between what we observe from a motility point of view to the bowel habit that we can observe in IBS. There are links when it comes to the sensory function measured by different tests of sensation and the symptoms of pain and bloating in IBS. And there is also a weak correlation between measures of intestinal secretion and diarrhea predominant IBS. Nowadays, there are also a multitude of other pathophysiological mechanisms, as we all have heard multiple times during this meeting. Signs of immune function or dysfunction, alterations in the brain-gut axis regulation, and as we just heard from Mirjana, which I will not dig into anymore, of course, the GI microbiota alterations. But also other pathophysiological factors like the function of the gut as a barrier, and also how we handle bile acids might be useful as potential biomarkers for disease or perhaps to predict treatment outcome. Starting out with rectal sensitivity, this has been shown repeatedly now, and this is from one of our studies where we had a huge number of IBS patients, 274 of them if I remember the figure correct, and 35 healthy controls. And as many others, we can show that the IBS patient as a group has a lower threshold for all the sensory components when it comes to the thresholds, and also perceives a higher intensity of sensation than healthy people do. And somehow also have a different referral area, that the painful sensation are referred to a larger area compared to the healthy controls, and also are a little bit differently expressed. In our hands, we can say that about half of the group of patients with IBS can be considered as being hypersensitive. That is defined as thresholds for the healthy controls -2 standard deviations. This seems to also be, we can reproduce, this has been reproduced in many cohorts. And if we look at this, where we have 5 different cohorts of IBS patients with functional gastrointestinal disorders, 4 of the cohorts are from patients with IBS, and 1 cohort is from a group of patients with functional dyspepsia. This is from Belgium, Leuven. These are from Chapel Hill in the US, and these are from Gothenburg. We can see if we look at the measure of sensitivity, Barostat protocol in all of these cases, and divide that into terciles of low threshold, mid threshold, and high thresholds for sensation, you can see that if you translate the measures of symptoms into set scores in order to be able to compare them, you can see that there is that the lower the threshold, the higher the symptoms are throughout all of these cohorts. So it seems to be a phenomenon that can be reproduced in a way that has been consistent over the years. The problem is to define cutoffs, and looking at how to define cutoffs when it comes to sensory thresholds when doing rectal distensions, there are people who have looked into that. And as you can see, somewhere around 28 to 26 millimeters of mercury gives a rather high specificity but a low sensitivity. That is, there is a lot of IBS patients that are also having normal sensory function, defined as if you compare them with the healthy controls. And the problem with the rectal distension or the sensory protocols is also that you can't really tell IBS apart from other diseases. It has a reasonable ability to tell a proportion of IBS patients apart from healthy controls. But we have difficulties, for example, to tell IBS patients apart from IBD patients, which shows the same phenomena of rectal hypersensitivity. Looking at transit measurements, what they can do for us, what is obvious, regardless which type of methodology you use, scintigraphy, radiopaque markers, or the more recently available smart pill device, you will end up with a large proportion, 70 to 80% of IBS patients that have the same transit measures as a healthy control. But there is a proportion of IBS patients that deviate from health with accelerated or delayed transit, and it seems like we can, by use of these transit measures, foresee that there is a higher abundance of the phenotype of IBS-C and functional constipation in the delayed transit group, and IBS-D and functional diarrhea in the accelerated transit group. That is, we can't really tell different functional bowel disorders apart, but this is one of the biomarkers that already I think some clinicians find useful as a biomarker for telling which patient might have an effect of laxatives or antidiarrheals, for example. These are new methods. These are both from the Nottingham group, from Robin Spiller, where he uses MRI to investigate the volumes of the bowel and the transit time. And what he has shown in this study some years ago is that the patients with IBS-D have lower volumes of water content in their bowel in the fasting state compared to healthy volunteers, apart from having a faster transit as well. And lately they had a new intriguing finding that they reported, where they seem to be able to tell apart the diarrhea and the constipation predominant patients from the non-constipated patients by the constipated IBS patients having significantly larger volumes of their colon, particularly the transverse colon. These are findings that still we don't know the clinical applications for, but this is probably one of the methods that will also be looked into in the future as a biomarker, perhaps to start out with telling subtypes of IBS apart, and perhaps also to predict effects of treatment. This is a suggestion from the Chapel Hill group how to look at the biomarkers we have today and how we can use them perhaps to distinguish IBS-C from functional constipation, perhaps in a better way than just asking the patient, do you have abdominal pain or not related to your constipation. By use of visual hypersensitivity that is more commonly seen in the IBS patient, that the delay in whole gut transit is more common in the functional constipation patient, as are measures of colonic hypomotility, colonic volumes, small bowel water content, and also if you add dysynergic defecation, you can have that as a marker, which is a bit more common in functional constipation. And this is something that is more and more up and coming, that you have combinations of markers and try to predict which category of which patient group are you belonging to. Looking into the bile acids is in focus mainly for the effects bile acid seems to have on transit when it comes to bowel function. There is a correlation between colonic transit time and the percentage of retention of a bile acid of a radio-labeled bile acid after 1 week. That is, if you have a low retention rate, the chances that you have a short colonic transit time is high, and IBS patients as a group has a lower retention rate than healthy controls, particularly when it comes to IBS-D patients. So this retention rate is related to an abnormal retention rate is associated with increased stool frequency, looser stool, and in particular accelerated left colonic transit. This can be measured by other means. This is from the US, where they use C4 as a marker of bile acid synthesis. If you have a high turnover rate of bile acids, which follows from an increased loss in the feces, you will have an increased level of C4 in serum. And this one behaves a bit like in the same way as the radio-labeled marker study that I referred to in the previous slide. And by combining colonic transit and fecal bile acid retention tests, you can increase the ability to tell IBS-C apart from IBS-D or controls, where the combined model behaves a bit better than the models by themselves, or the tests by themselves. Once more, combining biomarkers seems for now more promising than single biomarkers. What about mucosal immune activation, the immunology of IBS? For a long period of time, there is an interest in the low-grade inflammation there seems to be in IBS, as presented here a few years ago. That IBS patients seems to be able to tell apart when it comes to just the cellularity of the colonic mucosa compared to the healthy state, and also that you can perhaps tease apart the difference to other inflammatory conditions of the gut. A few years ago, I haven't seen this as a full paper yet. It seemed promising that you, by use of both the total immune cell count and the mast cell count, could tell IBS versus healthy part with rather high sensitivity and specificity. more importantly, also tell IBS from IBD apart with high sensitivity and specificity figures. But we are awaiting this as a full paper, though. We reported findings with relation to secretogranins, chromogranins and secretogranins a few years ago. These are proteins that are involved in secretion, secretory markers of secretion from endocrine cells, from immune cells, from mucosal cells, and so on. And what we could see was that there seemed to be a relation between chromogranin A and secretogranins and chromogranin B to IBS, with IBS patients having increased levels of these in feces compared to a decreased level of the chromogranin B in feces if we compare to healthy controls. This has not been evaluated compared with other pathological conditions, though, and we'll have one presentation in the next session as well by Johanna Sundin upon this topic. When it comes to serum and mucosal cytokines in IBS, we all know that this is a mix. This is a huge area of confusion, you can say, with slight changes if you look at individual cytokines in a univariate analysis. But if you try to compensate for other factors, it's very difficult to say the relevance of it. It looks like this, but if you do a factor analysis, as we have done here, we think that perhaps you can be able, by panels of cytokines, tease apart subgroups of IBS patients that are a little bit more immunoactive. In this cohort, identified by characterized by the levels of IL-6 and IL-8, and the healthy state more being characterized by higher levels of IL-10, with some association with an accelerated colonic transit time in the more immunoactive group. This has been repeated by us in collaboration with Chapel Hill in the US, in a cohort of them, where they also have measured serum cytokines compared with controls. As you can see, there are differences in individual cytokines. But if you look upon them in a principal component analysis, things look a little bit messy, but there seems to be at least a group of patients that is rather big here that don't involve any of the healthy controls. But in this cohort, we have poor correlation with symptom patterns. But there seem to be a part of the IBS patients that perhaps can be characterized by having a different immunoactivation. And this is something that many groups is looking into. And apart from having markers of immunological activity, other serum markers can also be used, like antibodies in this biomarker assay, which has a sensitivity of 50% and a specificity of 88% from telling IBS from non-IBS controls, which is reasonable. This is a fairly good number, but still we need more in order to have it as a clinical biomarker. Also adding other factors like fecal calprotectin in this study meant that they had a very high sensitivity and specificity telling IBS from healthy controls, and also had an association to GI symptom severity in association with the outcome of this biomarker panel. Other ways of looking at the bowel has also been reported, and one interesting part is the barrier the bowel as a barrier. By use of confocal laser in the microscopy, there are signs that both in IBS and in IBD that you have an increase in epithelial gaps, both in IBS and in IBD. And an abnormal gap density of 3% as a cutoff in this study had a 62% sensitivity and 89% specificity to identify IBS, tell them apart from controls, with a rather high positive predictive value and also rather high negative predictive value that follows. This needs to be repeated though. Interesting and a bit tedious way of looking at things if you should adapt it into your clinical practice. As we all know, the response to a meal is something that almost every IBS patient can tell us, that when I'm having a meal, my symptoms increase. And this is also something that we have looked into. Is this difference in response something that we can use as, for example, a marker of sensory function of the gut or by any other means? And what we have done is to explore nutrient and lactulose challenge test. That is, that we are having a high caloric meal combined with lactulose. It definitely is a challenge. And if we add 15 grams of lactulose or 25 grams of lactulose, you can see that with increasing amount of lactulose, the IBS population and the control population starts to spread apart when it comes to if we use biomarkers like the symptoms that they are reporting, but also the exhaled gas expressed as methane and hydrogen. This was also explored in combination in a further study, and what we can say that it seems like we can define a high gastrointestinal symptom group of patients that perhaps could be a surrogate marker for Barostat testing by use of this type of test instead, perhaps a bit of a more physiological test than expanding a balloon in the gut at the different levels. We have not been able to show that the fecal microbiota had any effect in this study, though. Another interesting biomarker that has not gained that much attention, though, yet are something called fecal volatile organic metabolites. And you can hear just by the name that this is something that perhaps is a bit something that we will avoid. Fecal volatile organic metabolites are breakdown products, chemicals from the metabolism within our gut, both from the microbiota, from the food content, and so on, which contributes to the odor of our feces. But there seems to be specific markers within these chemicals that might tell IBS apart from both IBD and the healthy situation. So this is something that might be of interest, either as a marker using feces or as doing the same type of measurements but in breath tests, where it seems to have a reasonably good ability to tell IBS apart from the healthy situation, and also is correlated to symptom severity depending on the level, the weighted level of different volatile markers. This is also another type of marker that has been investigated by the Pimentel group in Los Angeles. This is a bacterial toxin, and this is a protein involved in the tight junction system of the mucosal integrity. And as you can see, both the levels of the antibodies towards the bacterial toxin and antibodies towards this protein is increased in IBS, both compared to healthy controls and IBD. But the sensitivity and specificity for each one of these markers are intermediate, I'd say. This is also something that we're trying to use as a biomarker for IBS, psychological factors. We are all aware that anxiety and depression is associated with IBS. We also know that GI-specific anxiety is associated with IBS. Traditionally, it has been seen as something that is associated with increased symptoms, but perhaps nowadays we are starting to look at this as a potential marker that might be of importance also for the other way around, as a trigger for IBS. By use of symptoms apart from the core IBS symptoms, you might also be able to tease apart the IBS patients from from healthy patients. This has been evaluated by Robin Spiller by use of a question, the PHQ-15 questionnaire, where he took away the 3 questions related to gastrointestinal symptoms, and could show that having a PHQ value of more than 6 had a rather good specificity, even if the sensitivity was low for IBS. But it was quite uncommon that an IBS patient had a PHQ value lower than 6. PHQ-12 value lower than 6. And finally, while combining biomarkers and psychological measures, as shown here by use of a biomarker panel alone, or combining biomarkers and psychological measures, we can achieve a receiver operating curve that shifts to a position with a higher sensitivity and a higher specificity. So this is the way it looks. We can see that we have a lot of potential biomarkers with varying sensitivity and specificity. None of them are ideal by any means. Some of them are pretty good at telling IBS apart from the healthy state. Some of them are useful perhaps as a biomarker that can be used for prediction of treatment outcome and how to treat the patient. But in general, we have no clinically useful biomarker for IBS yet, but we have a lot of emerging candidates where we need to keep our eyes open for what the future will give us to use in connection with the current Rome criteria. Thank you.